Good afternoon. My name is Shelby Disney, and I'm the Outreach and Engagement Intern for the AARP Kentucky State Office. I'll be your moderator for the program today. With me is Louisville Community Team volunteer Rita Morrow, who will serve as our host today. Welcome and thank you for joining us. AARP Kentucky's First Fridays are a new interactive series designed to dive into critical health topics. These 30-minute virtual events aim to share valuable resources from professionals who work in the field and provide opportunities for attendees like you to ask questions in real time so that you can leave with answers in hand. We hope that you will ask questions today, and thank you again for joining us. Rita?
For today's event, we are joined by a representative from Hosparus Health, who will discuss hospice care and ways hospice care can help patients and families. At AARP Kentucky, we are dedicated to providing you with the information and support you need to lead a healthy and fulfilling life. Now, I would like to introduce Dr. Dustin Dillon, Medical Director of Palliative Care Services with Hosparus Health, to get us started today.
Well, thank you all for having me. Again, my name is Dustin Dillon, so I am the Medical Director of Palliative Care Services at Hosparus Health. I've been with the organization since 2017 and live locally here in Louisville. And just want to thank AARP Kentucky for having me today and being able to speak about palliative care and hospice care, what it is, what it isn't. And my goal today is hopefully that you all come away from this really understanding what palliative care and hospice care is and how they are different and similar, and also having a good understanding of what patients would benefit from both levels of care and how families and caregivers can also benefit from hospice and palliative care. The most frequent question that I get usually is, what is palliative care? You know, normally when I see a patient and or family, the very first question I ask them is, have you ever heard of palliative care before? And, you know, most people, there's two answers that I get. They either have never heard of palliative care, which is wonderful. That means that there is a blank slate that I'm working with and I can describe what it is that we do. The other half of patients really talk about end-of-life care. And so, you know, that is where I usually step in and say, well, let me explain to you what it is palliative care can offer. Palliative care is an extra layer of support for patients and families that are facing some sort of serious medical illness. The serious medical illness, especially in the adult population, a lot of times can be things like heart failure or severe heart disease, COPD or chronic lung disease, severe diabetes, history of strokes, dementia, Parkinson's disease, or things like cancers. So we serve any patient that has some sort of serious medical illness. Palliative care is really focused on quality of life. And so the rest of the medical community really is based on treating the actual disease or extending life, which is very, very appropriate. Our focus is not necessarily treating the underlying disease, but it's treating the symptoms that really affect the patient and family's quality of life. This may be things like pain, shortness of breath, nausea, vomiting, insomnia, all of those symptoms that arise when one has a chronic illness that can really decrease the quality of life on a day-to-day basis. We do that through expert symptom management, through use of medications. A lot of things that we have to offer aren't necessarily medications, but it may be lifestyle modifications. You know, one of the things many people don't know that have severe lung disease is that a simple fan to the face actually very much helps shortness of breath. And that's just based on how our brain works in telling our body how short of breath that we are. So really, expert symptom management is a focus of what we offer in palliative care. The other thing that we do is making sure that patients and families understand where they are in the disease process. So many of our patients and families have talked to 50 different medical teams. And sometimes it probably feels like you're hearing 50 different things. One of our goals is to really come alongside you all to say, where are you in your disease? Like, how long has this been going on? What do we expect the next few days, weeks, months, years to look like? So that then, number three, we can come up with plans or goals that really fit what is most important to you. At the hallmark of palliative care, and our motto is this is you-centered care. So this is the patient and family really telling us what's most important to them and what they value. So that's palliative care. It's an extra layer of support for patients and families that are facing some sort of serious medical illness, like what we talked about. If you compare palliative care to hospice care really is palliative care, but it's for folks that are in the final 6 months of their life based on what doctors or medical teams think. Hospice care, again, is focused on those same sorts of things, just like palliative care. It's focused on quality of life, improving symptoms, making each day as good as possible, but also coming up with a plan that really fits the patient and families. We want to hear from you all. Hospice care, again, is for patients that we feel like have a prognosis or a time of 6 months or less. Palliative care can be delivered at any point in the patient's trajectory. So whether you have a few months to live or a few years to live, really it's the chronic illness that qualifies you for palliative care, and it's the prognosis or the time that qualifies you for hospice care. You know, folks always say, like, when is the right time to be referred to palliative care, or when is the right time to be referred to hospice care? I always say there's not a perfect time, but early referrals are better. The more time that we have to come alongside you all and work with you as a patient and family, the more that we will be able to help improve your quality of life. So it is never too soon to think about palliative care support. And when a patient is that we feel like is in the final 6 months of life, we want to get them in hospice care as soon as possible because it just gives them a robust wraparound support at home, not just with medical providers like myself or nurse practitioners, but it also offers in-home nursing care, medical social workers, chaplains, volunteers, certified nurses aides that can help with kind of those daily activities that are really difficult, such as bathing and toileting and things like that are really, really difficult for caregivers. So early referrals are amazing, and we love early referrals. There is never a time that's too early to think about palliative care or to think about hospice care. You know, when we think about who can refer to palliative care or hospice care, we can take referrals from anyone. So this does not have to be a physician that is making this referral. We accept at Hosparus Health and at Palliative Health Partners, which is our palliative care business line, we accept referrals from anyone. So we have a lot of patients and families that call us up and say, hey, we heard about this program. We would like to know more. Do we qualify? How can you all best help us? And we would love to hear from you all. So even after today, if this is something that you're like, Dustin mentioned, like patients living with heart failure could benefit from palliative care, give us a call. We would love to help support you and talk with you about how we can best be supportive. But anyone can make a referral to hospice care or palliative care. So how is hospice and palliative care paid for? Our palliative care program, anytime our provider comes to see you, and we typically see patients about once a month, and that may be a physician like myself or a nurse practitioner. And again, you still have social work support and things like that. We just bill your insurance just like any other medical provider. So if you go and see your primary care physician or your cardiologist or your oncologist, that's the same way for us. We see you and we submit a claim to your insurance. Pretty much all insurances cover those palliative care visits. There may be a co-insurance or a co-pay that is due, just like any other physician visits. This is very different from hospice care. So hospice care is a Medicare benefit. And even for patients that don't have Medicare, that may have Medicare Advantage plans or other commercial insurance plans like Anthem, Blue Cross Blue Shield, things like that, pretty much all of those payers have a hospice benefit that gives you 100% coverage for the hospice care that you are receiving at home. And that reminds me that our palliative care program and hospice care can be delivered wherever you call home. That truly may be your house of residence or your apartment or your condo, may be an assisted living facility or a long-term care facility. We have clinics that are available for our palliative care patients. And we also have a robust telehealth program to where we can connect with you really, really quickly, just kind of like what we're doing today over a video screen. And those visits have been absolutely incredible to be able to improve patients' quality of life and intervening on symptoms that pop up sometimes in a very, very unexpected way. The other thing that we have here at Hosparus Health in both our hospice care program and our palliative care program are a couple of different specialty care programs that really focus on patients with either heart disease or lung disease. And we have a brand new dementia care program as well that really offers not just the patients, but their caregivers extra education on their disease process. It allows for extra kind of medication management or what we call kind of crisis plans. It seems like any time a crisis happens, it always happens at 2 a.m. Nothing ever seems to happen during normal business hours. But we have specialty programs that are really designed to focus on getting rid of or helping your symptoms in a very timely manner so that you don't feel like, oh my gosh, the only thing that's available to me is going to the ER or to the hospital. ERs and hospitals are absolutely wonderful and appropriate for a lot of our patients. But if you all are like me, if you don't have to be in an emergency department or in a hospital, most patients would much rather be at home or in their long-term care facility, wherever they call home. Our job is to come up with plans to help you live your life wherever that is, rather than feeling like we need to be running back and forth to the hospital. So again, palliative care is an extra layer of support for patients and families facing that serious medical illness. Hospice care is a robust level of support for patients that are in the final 6 months of life. It looks like there's a question from the chat from Shelby, so I'm happy to entertain that. So what is the best way to start the conversation? Many people see this type of care as giving up. Thank you so much for that question. This is probably the thing that I do the most on a daily basis. Starting the conversation really is coming to patients and families in a very non-threatening way. When I see a patient and family for the first time, I just want them to know that I care about them, that we care about them. And what matters to us really is what matters most to them. Like, we want to hear from you all and say, what is most important to you? When you think about the coming weeks, days, months, whatever that is, what does that look like to you? What do you want that to look like? What are you hoping for? What are you worried about? And with all of those questions, those open-ended questions that we really want to know, we are really able to figure out what patients and families value, so that then we can come up with a plan that really fits what makes the most sense for the patient and families. I think the second part of that question is many people do associate palliative care or hospice care with, quote, giving up. I just had a lovely conversation with a young couple yesterday that are facing a serious medical illness, and they're struggling with that too. And it absolutely is a real feeling. And that's one that I also want to validate and like say, I may not know that you're feeling this because I've not lived it, but I certainly hear this from a lot of the folks that I take care of. The thing about palliative care and hospice care is it really gives you all as patients or as families and caregivers, it gives you back a lot of control to say, you know what, we've been on the medical merry-go-round, we've been in and out of the hospital. What we've been doing is just not seeming to help as much as it used to or as much as we would like. And so to me, actually getting palliative care support or coming on board with hospice care is the opposite of giving up. I actually think, there's so much conversation around the fight against cancer or the fight against heart disease. And we should acknowledge the fight that our patients and families are going through. But sometimes we have to change what we're fighting for. Sometimes we have to say, gosh, I was fighting my cancer with all the chemotherapy and immunotherapy that our oncologists had. Now I'm going to fight for something different. I'm going to fight to stay at home and spend time with my family and focus on my quality of life rather than focusing on the fight against the disease. I'm actually focusing on fighting for my person. And that's what we want to focus on in palliative care and hospice care. I think there's another question that was just put in the chat. Who can refer families to hospice and palliative care? Anybody can refer a patient for palliative care support, and anyone can refer a patient to hospice support. We do get a lot of referrals from our hospital colleagues, whether that's here in Louisville at Norton or Baptist or at U of L. We get a lot of referrals from primary care offices and subspecialty offices like cardiologists and neurologists and things like that. But we get so many referrals from people that are out in the community that heard about us maybe on a webinar or heard about us on the radio or had a friend or family that was getting palliative care or hospice care. And they said, you know what, this may be something that I can benefit from. You can absolutely make a referral for yourself or your loved one. Again, we would love to hear from you. So anyone can make a referral for this type of care. Our job is then on the palliative care side, or if you're in hospice care, is we will work with your primary care physician or your oncology team or your neurology team, whoever that is. We will collaborate with them so that everyone is on the same page so that we are delivering the type of care that's most important to you. And I didn't say this earlier, but if you are in hospice care, and especially if you're in palliative care, you can continue to see your other physicians that you've been seeing maybe for 30 years. You do not have to give up your other physicians or stop seeing them just because you are receiving this extra layer of support. And so again, if you come away with nothing else today, I know I've said it probably 4 times now, palliative care is an extra layer of support. Hospice care is an extra layer of support for patients that are in that final 6 months of life. I think there's another question. My mom is in mid-level dementia and doesn't know where, but she is, so mentally doesn't know where she is, but physically okay, other than blood cancer. And she gets monthly Procrit injections. So Procrit is a medication that helps boost your blood system. She's near 90 and wants to die and be with my dad and sister. Is hospice right for her right now? So that's a great question, Vicki, and thank you for putting that in the chat. I don't know from reading that if hospice care is appropriate for your mom, but certainly palliative care is appropriate for your mom. And I think we would love to be able to serve your mom and kind of help you determine, like, where are we in the disease process? Are there other things going on with your mom that would make us worry that maybe we are in that final 6 months of life? I always tell people I'm a worrier by nature. I am paid to worry, and I worry about my patients and families. One of the things we will always do is be open and honest with patients and families about what we're worried about. if I see somebody and I think, gosh, I think time may be getting short, maybe measured in a few weeks, we're going to have that conversation with you all, because you all need to know that in order to make the decisions that make the most sense for you or your loved one. So, again, Vicki, thank you for putting that in. I don't know if your mom's hospice eligible just from knowing the little snippet that you gave, but certainly with her advanced age and everything that's going on with her dementia and her blood cancer, I do think that an extra layer of support to help your mom and you as probably your caregiver is really, really appropriate. And we would love to hear from you.
Okay, thank you, Dr. Dillon. You've offered a lot of great insights on hospice care. We're going to continue our Q&A portion here. Our member have several questions on end-of-life care, several things they'd like to know. So Rita, you want to ask a question?
Yes. How does hospice care address the emotional and spiritual needs of patients and their families?
Great question. This is hospice care at its core is based on holistic care. And by that, I mean, when someone is sick or someone you love is sick, it's not just the physical that matters. In fact, I would argue a lot of times it's the emotional, it's the psychological, it's the spiritual components of having a serious medical illness. And especially as we draw closer to end of life, a lot of times those emotional, psychological, psychosocial, and spiritual issues are more important to people. Hospice care and end of life care is an interdisciplinary team approach. It is a team that helps take care of patients and families. And so, again, it's not just the doctor or the nurse practitioner or the nurse. Certainly, you have that, but we have wonderful medical social workers that can deal with the emotional and psychological aspects of having disease. We have the best chaplains in the world. I know I'm biased, but we have wonderful chaplains that can come alongside and address spiritual concerns, regardless of whether a patient is religious or spiritual or not. It doesn't matter to us. What matters to us is hearing from you. And so we address all of those components through our interdisciplinary team approach. The other thing that is available for all patients that are in hospice care, and certainly after a patient dies for their family, is we have a wonderful and robust grief counseling center. So we have grief counselors that can help with what's called anticipatory grief. So that's that grief, that feeling of loss before something happens. And all of that is covered underneath the hospice benefit. So even after a loved one dies, under the hospice benefit, patients or families get another 13 months of bereavement services through our grief counseling center to make sure that we're supporting families through that time. So again, it's hospice care and end-of-life care is a holistic approach that really utilizes the entire interdisciplinary team.
And so, Dr. Dillon, as we think about the caregivers, so often we are focused on the patient and not quite as much on caregivers. So as we think about caregivers during this time, what resources are available for them during the time that they're caring for their loved one?
Yeah, I always share with folks, I went through a loss in my family with my sister, and I was one of her primary caregivers. I never understood what our caregivers went through until I did it. And I remember one day sitting next to my sister, her name was Angel, and I had this moment of like, oh my goodness, our caregivers are struggling to help take care of their loved ones. And they are doing such an amazing job. When we think about hospice and end of life care, you'll notice today that I always say the patient and family or the patient and the caregiver, because at the core, at the center of the care that we provide, it's not just the patient, it's all the people that are around them that love them. One of the very tangible ways that we help in hospice or end of life care is through that wonderful, robust CNA support, that those certified nurses aides that can come out as loved ones are declining and help either teach the caregiver, how do we bathe the patient if they can't get out of bed? Let me show you what a bed bath looks like. Let me actually come out 3 times a week to provide that level for you so that you can have an hour to just be able to sit and love on the person that you loved, and we'll take care of the bathing component from it. The other thing that we offer really for caregivers is, again, I go back to the interdisciplinary team. It's that psychological and emotional support from our chaplains and our social workers and from our medical team, from the RNs and physicians and nurse practitioners, to just really focus on the caregiver and say, you all are doing an amazing job. At the end of every one of my visits, I say this to every one of my caregivers because I mean it. I always tell them, you are doing everything perfect. That doesn't mean like you feel like you're doing everything perfect, but you absolutely are. The most important thing as a caregiver is to be present with the people that you love. That's what they want. As a caregiver, we want to do the best job we can as being a caregiver. Our job is to focus on and give you the skills and the language sometimes necessary to be a caregiver. So many times people will say, well, my mom has dementia and she says something. I don't know how to respond. And that causes a lot of stress and burden on me. And we can sit down and say, well, let's talk about that. How do you think about that when your mom says something that is, kind of out of her personality or you've never heard her say before? Let's talk about how to respond to that. So again, at the core of what we do is not just the patient, it's the caregiver as well. So that's an excellent point.
Thank you for that. Now, I know that you've already said hospice care could be given in the home, but what are the advantages and the challenges of receiving hospice care in a home setting?
I think the benefits are numerous, and the challenges, while although there are a few, I always tell folks the challenges of in-home care, that lies on us because that's our job to do. We want to remove things from people's plates. Certainly, our patients and families already have too much on their plate. We don't want to add to that. I think the benefit of being at home is that patients are much more comfortable where they feel comfortable, and they feel comfortable in their home, whether that's in their bed or in their living room. I saw a gentleman last week in our visit at home. We did it out on his patio overlooking his field, and he was in his wheelchair. And he said, this is where I'm at peace. This is where I feel the best. And he said, do you want to go inside? And I said, absolutely not. We're going to do the visit out here. So providing in-home hospice care is such a benefit for patients and families because they are where they feel comfortable. As you all know, being in the hospital, everything beeps. You never can get rest. It's uncomfortable. The beds are uncomfortable. The chairs are uncomfortable, all of those things. And so for us to be able to keep patients at home, especially through the end of life, that's where patients are and families are most comfortable. And I will say, if we get to a point that we say, you know what we're doing in the home, this patient is just not comfortable, we have the ability to utilize our inpatient hospice care center. That's our hospice staff to say maybe a patient needs a lot of IV medicine because they have terrible pain from their cancer. What our patients and families want more than anything is, especially at the end of life, they tell us all the time, I don't want mom or my brother or my child, I don't want them to suffer, right? And our job is to alleviate suffering. So if we're not able to alleviate suffering in the home, let's get the patient and family to a place where we can adequately alleviate suffering. So while there's certainly challenges in the home, those challenges, we are really good at navigating those and keeping patients at home because that's where they're the most comfortable.
Okay. Thank you, Dr. Dillon. We got another question from Facebook. It says, what is the biggest barrier for families when trying to obtain hospice and or palliative care services?
I think there are two big barriers. I think the first one is the misconception about what palliative care is and certainly what hospice care is. So many of people associate palliative care with end of life and quote giving up, right? And we've already talked a little bit about that. I always tell people again, palliative care, we are here to help. Our job is to focus on your quality of life. And so many of our patients and families are struggling with, I don't feel like my quality of life is where I would like it to be. And many times that's because of something very specific like pain. I think the other thing with hospice care, because it is a Medicare benefit, there are some things that don't mix with hospice care. And that's because of a financial thing or a financial reason based on Medicare rules and things like that. So, for example, some patients that have cancer that want to continue receiving chemotherapy, I absolutely support that. And if that's the most important thing to them and what makes most sense to them, let's continue to do that and continue to talk about when does it not make sense for you. But for a lot of patients receiving chemotherapy, they can't get hospice care and get chemotherapy at the same time. And that's because of Medicare rules. So sometimes there are medical specific instances for a patient that may be a barrier to hospice care. But the thing we see more commonly is folks are just, they're scared of palliative care. They're scared of the word. They're scared of hospice care. And I always tell folks, I'm like, let's talk about that, right? It's okay to hear a word and feel scared. I just want you all to understand that we are the folks that are truly here to help. We care about our community, and you all care about the people you love. And our job is to help you care for them at home.
Okay, Dr. Dillon, one last question. Let's say the patient is in hospice and then they start to improve.
Yeah.
Because we can't really guess when we are really down to the last 6 months.
Mm-hmm.
So what happens when they improve and they are receiving hospice care?
Great question. So the prognostic question is a good one, meaning, people ask all the time. And I know the question before they ask it, they'll say, Doc, I got a question for you. And every time after that, they say, how long do you think I have? And I always say, well, do you have a sense of how long you may have? And we talk about that. I always laugh and say, as a physician, and especially as a hospice and palliative care physician, one of my areas of expertise is supposed to be prognostication. Well, I'll tell you, my crystal ball is quite cloudy a lot of times. And we do see patients that come on to hospice care and actually end up improving. And they get to a point to where we think, I don't think they're in their final 6 months of life anymore. If that happens for a patient, our hospice team works with your PCP or your specialist, and we will work on a transition plan to kind of have you step out of hospice or discharge from hospice. That happens a decent amount. Well, guess what happens? If you step out of hospice or discharge from hospice, and let's say in 2 weeks something happens and we're like, oh my gosh, we're kind of right back where we were 6 months ago, and we think we are in the final 6 months again, you can very easily re-enroll in hospice. It's never a one-way street. Just because you sign up with hospice, it doesn't mean you're stuck in hospice. People sometimes come on board and then they say, you know what? I actually do want to go get some more chemotherapy. And we absolutely support that. And then they step out of hospice and we always welcome them back.
Thank you so much, Dr. Dillon. On behalf of AARP Kentucky, I'd like to say thank you for joining us today and sharing your valuable insights and knowledge on hospice and palliative care. Do you have any final thoughts you'd like to share briefly with those watching today?
Again, just want to send a big thank you to AARP Kentucky. I think this is a wonderful venue to be able to share information to our folks out in the community. And again, I work for Hosparus Health. And so if you all know anybody or you have questions about our program, we want to hear from you. And I mean that. We care about you all. We want to be able to serve you. So please feel free to reach out.
Thank you so much. To those joining us online today, thank you for joining us. We hope you learned something new. We also hope that you'll join us on Friday, November 1st at noon to hear about Alzheimer's, the Alzheimer's Association. Again, thank you so much for joining us. Thank you, Rita, for being here, and we hope you have a great Friday.